ACA provisions that have already been in place or are set to go in place. So how will the passage of ACA impact the overall cost of health insurance? We get asked that question a lot. There are several plan fees and requirements that definitely will drive up the cost of health care. First, a couple of the plan provision changes, eliminating pre-existing conditions. By 2014, plans will no longer be able to have a pre-existing clause on their health insurance. In addition, certain health benefits, what are considered essential health benefits and coverage, health plans will not be able to have any kind of limits on the amount of coverage for those benefits. And then there are several fees that go into place. And the first one, the comparative effectiveness fee, is already in place, and it's $2 per member per year, and that's in place from 2012 to 2019. And this is basically a research fee. And then there's what's called the health insurance fee, and it helps fund certain aspects of the ACA. Then we have the Transitional Reinsurance Contribution Program, which is a program designed to help reimburse companies that insure high-cost individuals within the individual health insurance market. These three together will result in an approximate 3.5% to 4% premium increase on your health insurance. So as you're getting your renewals for 2014, you will see these fees added, and many insurance companies are billing them completely separate from your premium because they want to make sure that you're aware that these are fees completely associated with ACA. The employer has three options. They can pay the fees, they can pass them along to their employees, or they can split them with their employees. And there'll be more guidance coming out on how that's going to work. And then finally, there's the Cadillac tax, and that doesn't go into place until 2018, but that is a 40% excise tax on the value of health insurance exceeding a certain threshold. Now I'm going to highlight some of the provisions already in place. While the major changes resulting in the individual and employer mandates, along with the exchanges, go into effect in 2014 and 15, we've already seen some impact on group health insurance plans. I mentioned that no pre-existing conditions by 2014. Currently, the pre-existing conditions for children has been eliminated, and then it will be extended to everybody in 2014. Health insurance plans are required to extend coverage to age 26, so a parent may keep their dependent on their coverage up to age 26, even if they're not a student. Limits on annual and lifetime limits, and as I mentioned in 2014, those are completely eliminated. Right now they are limited. Preventative coverage is at 100%, such as your annual physical needs to be covered at 100% without any copays or deductibles or things like that. And the vouchers were actually removed. This was a provision in the initial legislation. I included it only to illustrate how fluid some of this bill has been and how it continues to evolve since it has been passed. Some other provisions that are currently in place, the value of health insurance on W-2s. If you produce more than 250 W-2s, you have to include the value of health insurance on them, and that was in place this year for this year's W-2s. The summary of benefits and coverage, otherwise known as an SBC, is a clear and concise summary that you need to provide to all those enrolling on the effective date, and each year they re-enroll. Medical loss ratio rebates. Insurance companies in the large group market must spend at least 85% of the premium dollars on medical care and quality improvement activities, and then it's 80% in small group. Large group is 50 or more. If those thresholds are less, for example, if the insurance company only spends 78%, they must issue refunds to all plan participants. And then those refunds are sent directly to the plan sponsor, who's responsible for allocating them between the plan participants for that year, including terminated employees. The Medicare tax on high wage earners was increased this year, so if you have anybody in your community who earns over $200,000 per year, an additional 0.9% payroll tax is being withheld. Flexible spending accounts, the health FSA limit is $2,500 is the maximum that you can offer on a flex plan. And then later this year, we will be required to notify all our employees, not just full-time, all employees of the exchanges and their rights under the exchange. That was supposed to come out in March. It's been delayed to late 2013. And a model notice for that notification has been provided by the Department of Labor. The non-discrimination clause, the effective date for this is pending. We are hearing it may be released sometime in 2014, maybe 2015 with more guidance. But how it is written today is that if you offer health insurance plans, in order to be in compliance, you need to have exactly identical employee contributions for each benefit level. You can't vary based on age, years of service, or compensation. The same type of benefits. When I say benefits, I'm only referring to health care, but you would not be able to offer a richer plan to your highly compensated employees than you do to your line staff, for example, and you won't be able to have different waiting periods. As I said, we're still waiting for guidance on this, but it's important if you do offer a management carve-out or provide different levels of benefits for certain classes of employees to diligently be looking at how this will impact your plan. Because once it does go into place, the penalties are significant. So now I'm going to move to 2014, where, as I mentioned previously, some of the more major provisions take effect. The complete elimination of pre-existing conditions and no annual dollar limits, which I already mentioned. The third one is pretty significant and impacts a lot of senior living communities. Waiting periods cannot exceed 90 days. That means that if you have a waiting period for health insurance that is first of the month following 90 days, that would be out of compliance because your employees would essentially be going over 90 days before their benefits kicked in. And most health insurance carriers require you to start someone's benefits on the first of the month rather than prorating. So what this is going to mean is that if you do have a waiting period over first of the month following 60 days, you're going to need to change it to the first of the month following 60 days. No cost sharing in excess of the limits on high deductible health plans. There are some limits on how much you can, if you offer a high deductible health plan, how much additional excess that employees can be required to pay. And then limits on wellness incentives are going to be increased. Currently, you can do a 20% differential on certain wellness incentives. It's going to 30, and then 50% for smokers in 2014. And I am going to talk more about wellness at the end of the presentation. In 2014, health insurance programs will be required to cover routine costs of patients who are part of clinical trials. As I mentioned, the state exchanges will be set up, the individual mandates go in place, and then the employer mandate regarding coverage, which has been delayed to 2015. So now I'm going to touch on the mandates. Here's how the individual mandates look starting in January 1st, 2014. All U.S. citizens and legal residents must have health insurance or they're going to pay a penalty. There are some exemptions to that. They're very few and far between. There's certain religious exemptions, if you're in prison, things like that. They're very few and far between. But as you can see from this chart, the penalties are pretty low, especially initially. It is the higher of the 95 per person or 1% of taxable income. But for a lower wage earner, this amount can be pretty minimal. So we don't anticipate that healthcare participation is going to increase that significantly with some of the lower wage workers just because of the penalties being so low initially. But you can see they do start to go up. The individual mandate is not anything the employer needs to administer or inform their employees of. This will be something when your employees have their taxes done each year. If they didn't have health insurance, that's where the penalty will be applied. I'm going to cover the employer mandate, even though, as I've mentioned, it's been delayed to 2015. But basically, the law doesn't require employers to offer health insurance. However, large employers, and I'm going to go through what a large employer is, will be subject to a penalty beginning in 2014, and I apologize, that should be 2015. These slides had to be redone pretty quickly after the announcement a couple weeks ago. If they do not offer coverage, if they offer coverage but it's not affordable, or the coverage does not meet the minimum essential standards. So what is a large employer? A large employer is an employer who has 50 or more full-time employees or full-time equivalents, so FTEs. Full-time employees are those that work 30 hours or more per week, and that's calculated on a monthly basis. FTEs are calculated only for the determination of whether or not you're a large employer. So there's no penalties associated with those that work under 30 hours a week. However, their numbers do go into the calculation to determine if you're a large employer. So for the 50 FTE calculation, here's an example. This employer has 40 full-time employees and 20 part-time. And those 20 part-time work 24 hours a week. So what we would do is we would take the 40 full-time, and those all count as one. And then the part-time, you take the number of part-time times our hours per week, and then we back it into a monthly, weekly, and then a month, and then we divide that by 120, and that gives us 16 full-time equivalents. So in this example, there's 40 full-time plus 16 full-time equivalents, so 56 employees, full FTEs, so they are considered a large employer. The penalty only applies then with respect to the full-time employees, however. So if you offer health insurance coverage in 2015, it still has to be deemed affordable to avoid penalties. The plan can be deemed unaffordable if the employee's required contribution is more than 9.5% of the employee's W-2 Box 1 wages. When this initially came out, it was the employee's household income. A lot of employers spoke up and said, we don't know employees' household incomes. How would we ever determine that? So that has been amended to say that we can use their W-2 Box 1 wages. So that's one of the criteria on affordability. The second one is that the plan needs to pay for at least 60% of covered health care expenses. If it does not, then it's deemed unaffordable. There are a couple different options for determining that 9.5% when you're putting your contribution strategy together. The safest method, that's being referred to as a safe harbor, is to look at the bottom of the federal poverty scale. And that number currently for 2014 is $11,490. So the federal poverty scale says that's the minimum, or that's the low end of what a full-time worker in this country could possibly make. Take that times 9.5%, and it gives you $90.96 per month. So if you make sure that your employee-only maximum monthly premium is $90.96 per month for a plan that pays for at least 60% of covered health care expenses, then you likely have covered yourself and will avoid any penalties. You can look at the minimum wage. You can also just look at your lowest paid worker. But to be absolutely safe, foolproof, we recommend using the federal poverty level if you're able to do that financially at your community. So I'm going to talk about how the penalties work. If you don't offer coverage, the penalty applies if one full-time employee receives federal assistance to purchase through an exchange. And then the penalty is $2,000 multiplied by the total number of full-time employees, not taking into account the first 30. So they allow us to deduct the first 30. For example, if you had 120 full-time employees, you don't offer health insurance, at least one of those employees purchases health insurance in the exchange and is eligible for a subsidy, then you're going to pay the penalty on 90 of them. 90 times 2,000 is $180,000. If you offer coverage, but it's not affordable, the penalty is $3,000, but it's only by the number of full-time employees who receive assistance in the exchange. It's not by everyone. And it's never going to be more than what you would have paid for not offering coverage. So in this example, let's say that you have 120 full-time employees, 30% of them receive assistance in the exchange. The penalty calculation would be 36 of those employees times 3,000 equals $108,000. The penalties are assessed on a monthly basis, and they'll be paid invoiced directly to the IRS. They'll start accruing on January 1, 2015 for calendar year policies. Penalties will start accruing on employer's renewal date for those with transition relief. What that means is if you're not on a calendar year plan, as long as you have a plan in place at the end of December of 2014 that's extended to the majority of your employees, then you are able to wait till your renewal date. So for example, if your renewal date is March 1st of 2015, you do not need to comply until that date versus the January 1, 2015. Auto-enrollment, this is another provision that's been delayed. Auto-enrollment will require employers with over 200 FTEs to automatically enroll their employees into the health insurance plan. Employees can then opt out. There's not a lot of guidance out there yet on how this is going to work, how long the employee has to opt out and things like that, but just know if you have over 200 full-time employees, your participation in the health insurance would likely go up as a result of this provision when it is rolled out, which is likely going to be 2015. I've summarized here a little bit about how the employer administration is going to work. There's going to be a lot of requirements for employers. A lot of it's going to fall on HR and payroll taxes, but you'll need to determine, first of all, if you're a large employer, you're going to need to determine employee status, ongoing tracking to make sure that full-time employees are being offered benefits. You're going to need to track the measurement and stability periods, which I'm going to talk more about if you have employees who work variable hours, which I would imagine you all do. It would be very critical to notify employees timely of eligibility. If you're part of a control group, if you have multiple communities or a corporate office, you'll need to determine if you all need to be grouped together for purposes of the non-discrimination and for purposes of the large employer status. You need to ensure your plan meets the affordability standards. You can look to your carrier and your insurance agent to try and do that for you, but a lot of them don't want to comment on whether or not the plans meet that 60% test. So there are some different ways that you can analyze your plan to make that determination. You're going to need to notify your employees of the exchange, the W-2 reporting, the medical loss ratio rebates if applicable, and then there's going to be reporting that needs to be done to the IRS. Some of this is already in place, some is not yet. So I've talked quite a bit about employee status. I wanted to go into that a little bit more because I know this impacts a lot of you and how you operate your communities today. It has been delayed because it's part of the employer mandate. However, it's important to start looking at your staffing models now and be prepared. As I mentioned, a full-time employee are those that work 30 hours or more per week. Part-time employees are those who average under 30 or more per week. But then what do you do about all those variable hour employees that fluctuate between full-time and part-time? They're maybe PRN, they fill in when you have people call in, they fill in on vacations, leave of absences, and things like that. You have a couple options. The first option is to ensure that they don't ever go over 30 hours a week because the calculation is done on a monthly basis. So if they have a month where they averaged 30 hours or more per week, then they should be full-time being offered benefits. So you can ensure that that never happens, or you can take the safe harbor. And what the safe harbor is it allows the employer to take their variable hour employees and measure them for a period of time that is outside of that normal 30 hours per week. It gives you more time to determine and make sure that they're going to be variable hour part-time. You pick a measurement period, and that measurement period is a fixed amount between 3 to 12 months. You can pick 3, you can pick 6, you can pick 12. But that's a period of time you're going to measure these variable hour employees to determine whether or not they've averaged at least 30 hours or more of service per week. If they do during that time, then you need to offer them benefits for that same amount of time, which is called the stability period. So let's say, for example, after 12 months, they meet the definition of full-time, then you need to offer them benefits for 12 months. As I mentioned, the measurement period can be anywhere between 3 to 12 months. Your stability period will match your measurement period with the exception of 6 months is the minimum stability period you can have. So as you can see, it's very confusing. And as I mentioned, you do have some time to prepare, but if you have a lot of employees who work variable hours, this is an important provision to make sure that you're very educated on. Once you determine if they're full-time or part-time, if you do determine they're full-time, then you get another 90 days to offer them benefits. This chart illustrates a little bit about how that's going to look. And I'd be happy to go through this in more detail with some of you who may be really impacted by this. So now I'm going to talk about the exchanges and how they're going to work. Basically, there's going to be 4 plans set up: bronze, silver, gold, platinum, and they're just like they sound. The bronze would be the lower end plan, the platinum, the highest end plan. The rates for those plans are going to be based on age, tobacco use, geographic region, and then the coverage level. And then I'm going to talk more about how the subsidies are going to work on the next slide. There's also a catastrophic plan that's available in very unique situations, mostly to younger individuals or those with extreme affordability hardships. So this chart illustrates how the exchanges will work. They're all based on the federal poverty levels. The federal poverty levels up to 400%, anyone who has a federal poverty level up to 400% will be eligible for some type of assistance to purchase health insurance in the exchange. I start here at 133% of the federal poverty level. The reason I do that is because if you are below the 133%, you likely would be eligible for Medicaid assistance as long as Medicaid is expanded in your state. That is on a state-by-state basis, whether or not Medicaid will be expanded. But if it is, some of your very low wage earners will be eligible to purchase coverage there, and you have no penalties associated with that. So we're going to focus on those that would not be eligible for Medicaid. So for example, if you have an employee whose estimated annual wages are about $15,282, they're going to get a subsidy in the exchange, and their cost is going to be around $24. Again, this depends on what plan they pick. This depends on their age, if they use tobacco or not. But I really like to show this slide to illustrate how those costs continue to go up. And if you make over $45,960, there's no subsidy whatsoever. And I think this is really important for employers who are considering not offering health insurance. Many, many of your key employees would not be eligible for any type of assistance to purchase coverage in the exchange. So if you are not offering coverage to them today, then they're going to be paying a lot of money out of pocket for health insurance. The exchanges are really set up to help support and subsidize those lower wage earners. So whether or not you're going to play or pay, some things you want to consider. We hear a lot of employers saying, I'm just going to eliminate coverage, it's cheaper, I'll just pay the penalty. Well, that certainly is an option. This example, I recommend that you go through this with your community and do different scenarios and models of how it might look. But in this scenario, I've got 100 full-time employees at 100% participation, which is probably unlikely, but I use that as the top end. The employee-only premium is $400 a month, and the lowest salary at this community is $18,720 a year. The first thing I looked at is, let's say they just eliminate coverage. If they do that, they're going to pay the penalty on those 100 full-time employees minus the first 30. So they're going to pay a penalty on 70 of them. And then because so many of their employees are having to pay a lot more for health insurance in the exchange, they may have some recruiting issues they're concerned about, losing key employees, you end up giving a lot of salary increases. So your wages go up. And when your wages go up, your payroll taxes and your workers' compensation costs go up. And if you're a for-profit organization, you lose a major tax deduction for not offering health insurance. So the next thing you know, it's costing a lot more money to offer health insurance than it is to not offer it. And again, these are the different models that I suggest you just go through and figure out for your location what's going to work best. And then I took the highest compliance, which would be basing it off the lowest level of federal poverty level, and then the lowest compliance, which is off that lowest paid worker. Again, just looking at different scenarios and how much they may cost. Some other strategies you might want to consider. Healthcare reform only applies to health insurance. So if you have other benefits where you're contributing a large amount or even a small amount, those can add up, such as dental, you certainly could funnel those dollars towards the health insurance if you needed to, because you're only required to offer the health insurance and make it affordable. You certainly can hire more part-time people. I've had a lot of communities tell me that's their strategy. You might want to expect and budget for higher turnover costs if you do that. And then you can certainly discontinue offering coverage. And if you do, obviously the penalties that we discussed, I would anticipate additional wages, payroll taxes, and workers' compensation costs. And you also need to consider the type of impact that would have on recruiting and retention and what kind of disruption that would create for your residents if you had higher turnover. Now I'm going to touch on wellness and how that's impacted by the Affordable Care Act. Wellness and the law. The HIPAA rules, which define what's permissible, have been amended by the ACA. I would like to point out that the final rules on the wellness and ACA were just posted in May, so there's still some deciphering that needs to be done. But basically, they define two types of wellness programs. The first one is a participatory program, and what that is it doesn't require the satisfaction of any additional standards beyond simply participating. So you don't have any additional requirements to provide rewards. This could be helping to fund a gym membership, a company-sponsored lunch and learn on wellness topics, something very informal. And then the health contingent plans, and those are broken up to two types, activity only and outcome-based. Health contingent programs must meet 5 criteria. Keep in mind, though, that the affordability clause still applies. However, you can use the wellness incentives to structure a contribution strategy that rewards healthy behavior. Those criteria are eligible individuals are given the opportunity to qualify for the reward at least once a year. That reward may not exceed 30% of employee-only coverage or 50% for tobacco use. So for example, if the minimum affordability standard is such that your employees pay $100, you could offer that same plan to your non-smokers at $50. Note that the term of the use rewards, all of the language used to describe the wellness criteria is focusing on rewarding healthy behavior rather than punishing unhealthy behavior. The third criteria for a health contingent program is that it must be reasonably designed to promote health and wellness and prevent disease. And then there's the activity-based wellness programs and the outcome-based wellness programs. The activity-based, the full reward must be available to all similarly situated individuals by offering a reasonable alternative standard for obtaining the reward. For example, let's say that a walking program is what you'd like to put in place for a wellness reward. But maybe you have an individual that cannot participate due to certain health conditions. That alternative could be that they receive health coaching. If they complete that, they would still be eligible for the reward, even though they may not have been able to complete the actual walking program. An outcome-based program is one where the individual must actually attain or maintain a particular health standard to obtain the reward, such as not smoking or obtaining certain biometric results. However, again, that alternative standard still must be offered and the reward subsequently granted. So let's take tobacco, for example. If the individual uses tobacco, they still are eligible for the reward if the alternate standard is completing a smoking cessation program, and they do so, even if they continue smoking. So these rules have changed how we look at wellness quite a bit. And then the fifth criteria for a health wellness program is that the availability, reasonable alternative standard to qualify for the reward must be disclosed in all your materials. So it's got to be very available to your employees, and they have a complete understanding of what's available to them. As I mentioned, these final rules were just released, and the requirement for the alternative standard is a little bit confusing and contradictory to what we've seen in the past, but it will certainly have an impact on how wellness plans are administered today. So what should you do next? We just had a big delay, or other portions, provisions going to get delayed. They may. I don't think any of us can know that without a crystal ball. But my best recommendation, and what we recommend of all of our clients, is get prepared now, don't wait. Look at your staffing needs. Are you going to have enough staff at your location to do all the administration required? Make sure your health insurance plans do meet those affordability standards if your goal is to avoid any type of penalties. Do those play or pay models to ensure that you understand the financial impact of offering coverage versus non-offering it, and if you do offer it, at what level. And then start to work on getting your reporting needs set up. Work with your payroll vendor. If you do payroll in-house, work on how you're going to get those reporting set up to make sure that you're monitoring your full-time equivalents, your 30 hours or more a week, your employee status, and then any reporting that's going to be required to the IRS. With that, we are going to turn it over to questions. Again, I appreciate your patience earlier as we had some technical difficulties with our PowerPoint. Hopefully you all hung with us. I do have a question coming in here. Do I have to offer health insurance to my employees' dependents? And the answer is no. The affordability clauses and the requirement to offer health insurance for the employer mandates is strictly around employee-only coverage. When the bill was first passed, that wasn't real clear, but there has been since guidance provided that has opened that up and reinforced it as just employee-only that you need to focus on. Do we have any additional questions? If not, we will conclude. But if you have any questions, please email Charles Brubaker. His email should be on your meeting invite, and he will circulate those to me, and we will get those answered for you. Appreciate your time today and look forward to future webinars.